Hi, everyone. Thank you for joining us today. We are going to go ahead and get started. Let's see. All right. So I'm Sam Arsenal. I'm the Director of National Treatment Quality Initiatives at Shatterproof, and I'm joined by my colleagues, Leah Kaufman and Rebecca Rosenquist, as well as Research Triangle Institute, the data analytics contractor for this project. Today we'll be covering the proposed measure set to be used in the pilot of Shatterproof's rating system for addiction treatment programs. The measure concepts we will describe today are currently posted for public comment via the National Quality Forum website through March 1st. Following the public comment period, the measure concepts will be refined by Research Triangle Institute and implemented in the rating system pilot over the next 2 years. This webinar is a small part of the overall engagement related to the rating system, focused specifically on background information and the measure set in preparation for this public comment period. We hope that this presentation is useful in preparation for the public comment period in developing an understanding of the rating system project and the measure concepts themselves. Running through the overarching agenda before we go into more detail on the current measures, Leah will provide some background on Shatterproof's approach to the rating system and the current pilot. Then we will describe the process by which we arrived at the proposed measures, and finally we'll take a look at each of the measures in more detail. We'll have approximately 20 minutes at the end for questions, but before we begin, we just want to run through a few housekeeping items. This webinar is being recorded and will be provided to attendees after the session. Also, all of your lines are muted, so we ask that you please send all questions and comments using the chat function of the webinar platform. At the end of the presentation, my colleagues will facilitate the Q&A session using questions submitted in advance, as well as questions submitted through the chat function during the webinar. We've also received a number of questions in advance and have done our best to ensure that they are answered throughout the presentation. So thank you to those of you that have submitted questions or comments prior to the webinar today. If we don't cover something that you're interested in, or we don't get to your question at the end, you can always reach our team by emailing ratingsystem@shatterproof.org. With that, I'll turn it over to you, Leah, and we'll get started.
Great, thank you, Sam. Good afternoon, everyone. My name is Leah Kaufman, and I'm a State Engagement Manager with Shatterproof. I'll be working with several of our pilot states on implementation over the next year and a half. I'd like to begin by acknowledging the issue we're all here to address. In 2017, there were 19.7 million Americans with a substance use disorder, including 2.1 million Americans with an opioid use disorder. While we know evidence-based medical treatment improves patient outcomes and saves lives, only 20% of individuals with a substance use disorder reported receiving any form of treatment in 2017. Thankfully, addiction can be treated with the same effectiveness as other chronic diseases. Unfortunately, use of evidence-based best practices varies widely across the addiction treatment fields. Rating systems play an important role in bringing transparency and in bringing information on program quality to the public, which can help guide consumer treatment decisions. While rating systems exist in many other healthcare and commercial sectors, for example, CMS's Nursing Home Compare or Leapfrog's hospital rating system, no such system currently exists for addiction treatment. And that's why Shatterproof is leading a 2-year project to pilot a rating system for addiction treatment programs. The rating system will measure the quality of specialty addiction treatment programs included in SAMHSA's inventory of behavioral health services. This includes residential outpatient and intensive outpatient programs that are licensed, certified, or otherwise approved by states to provide substance use disorder treatment. It will also include facilities that, for a variety of reasons, the state does not fund, license, or certify. Measurement for the pilot will be done at the facility level, and in this first phase, it will not include individual providers. The end goal of our work on the rating system is to produce a web-based platform housing quality ratings that are publicly accessible. The platform will have portals for 4 audiences: people seeking care, providers who want to view their own quality metrics to help either target quality improvement efforts or to locate referral partners, payers, both commercial and public, interested in identifying high-performing providers, and finally, states looking for information to inform quality improvement initiatives and better target technical assistance. And on the next slide, you can see that the rating system is going to be pilot tested in a select group of states in 2019 to 2020. We're very grateful to the funders of this $5 million project. The pilot is majority funded by Arnold Ventures and the Robert Wood Johnson Foundation, and by a coalition of 6 national health insurers. The rating system pilot states are being selected based on several criteria, including readiness for successful implementation of the pilot and demonstrated potential to scale the rating system after the pilot. Following successful completion of the 2-year pilot, the rating system will be scaled nationwide. You may have seen in the last couple of weeks, Massachusetts and New York are the first states to publicly announce their participation. We're very excited to have strong state partners, and we're looking forward to being able to share with you the additional states that will be joining the pilot in the coming weeks. So please stay tuned for those announcements. And on the next slide, why a rating system? Because rating systems create opportunities. Our state partners have committed to share data to encourage and leverage their contracted providers to participate and to work with Shatterproof to increase awareness of the rating system. The rating system will give treatment programs the opportunity to benchmark themselves against their colleagues throughout the state, as well as to engage in quality improvement and to attract patients. Programs may also be able to leverage their participation or rating to secure enhanced reimbursement from contracted payers. Participating during the pilot allows providers to have more direct say about the design and the impact of the rating system. Your feedback early in the process will enable Shatterproof to structure the rating system so that it best serves the needs of all stakeholders. Shatterproof is working with state partners. We're also working with commercial payers to develop strategies to incentivize and reward provider participation. For example, requiring reporting to be eligible for higher network tiers or alternative payment models, or to contract with Medicaid. The rating system will also provide states and other stakeholders with necessary quality data to inform treatment access and provision of resources such as technical assistance. So how do we arrive at the measures that we're using in the pilot? On a high level, the rating system will examine whether addiction treatment programs are delivering care that aligns with the evidence-based best practices detailed in Shatterproof's National Principles of Care. These are core components of high-quality addiction treatment that were identified by a task force composed of subject matter experts, practicing clinicians, and policymakers. These are principles derived from the Surgeon General's landmark report and are all backed by decades of research. Measures used in the pilot align with national principles on this slide 2 through 8. And that's because measure 1 is related to screening, which takes place in the general healthcare setting and is outside of the unit of analysis for this pilot. We won't get into the principles in detail now, but there is more information about each of them on Shatterproof's website, including detailed definitions and rationale. So looking at payer sign-on to the principles of care, it was important to us that the principles spurred action and had an impact. So to that end, we released the principles just outlined on the last slide with the sign-on of 16 payers back in November of 2017. And these signatories agreed to identify, promote, and reward care aligned with the principles. There are now a total of 20 payers and covering over 250 million lives across the country who have signed on. This pilot takes the next step towards implementing and measuring progress towards these quality standards. And if you look on the slide, those listed in orange here are also together funding 1/3 of our current rating system pilot. So the rating system, what's being measured? It will report on the quality of treatment programs for all substance use disorders and not just opioid use disorder. Some of the measures will be specific to the treatment of opioid use disorder, and ratings based on those measures will be marked as such. The rating system will be informed by data from 3 sources: insurance claims, treatment program surveys, and a consumer experience survey. This information will be publicly available to those searching for high-quality addiction treatment, as well as to public and private payers, states, and providers. If a treatment program does not respond to that provider survey component, this will be clearly indicated on the rating system, and the measurement from other data sources will still be displayed. Shatterproof is utilizing this mixed method approach to ensure the rating system can capture as much quality information as possible, just given the current fragmentation in the addiction treatment system. The survey that treatment programs will be asked to respond to starting in summer of 2019 is being designed to align as best as possible with metrics that are already being reported. So when possible, information will be pre-populated in order to reduce the reporting burden to providers. Our data analytics contractor, Research Triangle Institute, or RTI, will also run a rating system help desk, and that will provide technical assistance to program administrators at those programs throughout the pilot. Shatterproof, pilot states, and the involved payers are all working to ensure that this process aligns as best as possible with current data collection, with the aim that in the long run, it will hopefully reduce reporting burden to multiple stakeholders. Treatment programs may be required to attest to certain items and or validate data submitted. Shatterproof reserves the right to audit a random sample of survey submissions to ensure data integrity. And data from alternative sources will also be used to validate that self-reported information when possible, for example, triangulating from claims data. So how are the measures selected? The measure set that is currently up for comment has undergone several iterations. Shatterproof began to draft the measure set for the rating system following the release of the National Principles of Care. And because we didn't want to reinvent the wheel with this project, our Quality Measures Committee began the process by creating a crosswalk of existing measures in this space and aligning them with the principles of care. This included national level measures vetted by NQF, NCQA, and others, as well as national organizations and initiatives, and work by federal agencies that were developing or recommending measures for substance use disorder treatment. This included ASAM, CMS, SAMHSA, NIATAX, and Optum Labs. And we started to refine the list by removing outdated and duplicative measures, and then began an iterative process to focus on impact and feasibility. After collecting and reviewing existing measures, the measure set was refined using the following criteria. Consistency with the national principles of care. We wanted to ensure relevance to providers and to consider the ease of collection and whether there was a history of challenges related to a particular measure. 5 expert meetings were held to discuss and further refine the measures, and concurrent to this, Shatterproof facilitated discussion with key stakeholder groups, including payers and providers. The feedback was then integrated into the draft measures that you're going to be looking at in a couple minutes here. So providers that took part in our focus groups were identified by leadership from trade organizations representing some of the key players at the national, state, and local level in the provision of substance use disorder treatment. And we wanted to thank the American Association for the Treatment of Opioid Dependence, the American Society of Addiction Medicine, the National Association of Addiction Treatment Providers, the National Association for Behavioral Healthcare, and the National Council for Behavioral Healthcare for connecting us with providers to participate in this process. The groups were virtual and were facilitated by the Technical Assistance Collaborative with support from Melville Charitable Trust. And as part of these groups, providers were asked to first prioritize measures, identify any obstacles or challenges associated with any of the measures, propose changes to existing measures, and to suggest new measures. And we also wanted to thank the providers and others who shared their thoughtful feedback throughout that process and acknowledge the important role you play in getting us to the measure set where it is today. So looking at timeline, following the refinement by the payer and provider processes, we turned the measure set over to the National Quality Forum. NQF began by conducting a landscape review of measure concepts independent of Shatterproof, conducting key informant interviews, and holding a technical expert panel. The measure set that is posted for public comment today reflects recommendations from each of those stages. Following the public comment period, the experts convened by NQF will make the final recommendations for the measure set for implementation in the rating system pilot this year. And it's important to note that the measure set that you'll be looking at today and that will be recommended may include some measure concepts rather than specific measures. In that case, survey questions or measure specifications will need to be refined by RTI. RTI will also conduct field testing of the provider survey and test the claims-based measures. If that's something that you are interested in being involved in those tests, please contact us. The rating system email will be provided at the end of this presentation. So as previously mentioned, NQF is soliciting public feedback right now on the measure sets that will be used in the pilot. Comments are due by March 1st, which, believe it or not, is this Friday, and by 5 p.m. Eastern Standard Time. We strongly encourage you to participate. Can't emphasize enough how important your feedback is in this process. And with that, I will turn you back over to Sam Arsenal, and she will take you through the measures.
Great, thank you, Leah. Now we will begin to go through the measure concepts. To start, we want to point out that the measures are not in the same order for this webinar as they are for the public comment period. For the purposes of this webinar, we have divided the measures by the 3 data collection sources. This was based on questions received in advance of the presentation to provide a snapshot of what information will be collected or asked of each of the 3 sources. For the public comment period, the measures are listed to align with the order of the National Principles of Care. However, the measure number is the same for each of the slide decks. For example, measure 4A, continuous engagement, which is the first claims-based measure we will discuss, is shown under Principle 4, engagement in continuing long-term care, in the public comment period. The detailed measure slides are the same for both presentations. We will start by walking through the 4 measure concepts that have been proposed to collect via insurance claims. These measures will be calculated using both Medicaid data and commercial insurance claims from our data contributing partners. This includes the 6 national plans that Leah mentioned, as well as state-specific health plans that we are beginning to partner with for this process. No raw claims data will be shared to inform the rating system. Instead, the measures will be calculated and the results will be shared with Research Triangle Institute, who will aggregate the findings across commercial plans and share the measures for the Medicaid plan. RTI will operate a help desk throughout this process. There is also a potential that claims-based measures will not be used to inform the public-facing measures during the first round of the pilot. In this case, all or a select number of the claims-based measures would only be used to report back to the treatment program. So moving through the claims-based measures, again, there are 4 at this point in time in the current measure set that is up for NQF public comment. The first claims-based measure is measure 4A, continuity of care after residential treatment for a substance use disorder. The technical expert panel, state partners, and clinicians determined that this was a more appropriate and reliable measure than the original claims-based measure, which was related to initiation and engagement in treatment. The next 2 claims-based measures are related to Principle 7, access to FDA-approved medications. Measure 7A looks at evidence of medications and is specific to patients diagnosed with an opioid use disorder. This will result in a rate of patients diagnosed with an opioid use disorder that are on any medication treatment for opioid use disorder, regardless of whether that medication is prescribed at the program that's being examined. The next claims-based measure related to access to FDA-approved medications is the continuity of pharmacotherapy for opioid use disorder. Again, this measure is specific to opioid use disorder and examines the % of people treated for opioid use disorder with medication for a continuous duration of time of 30, 60, 90, and 180 days. The last claims-based measure examines readmission to a higher level of care or admission to an emergency department, hospital, residential treatment, or hospital or community tenure. This measure may be reported at the population level. Importantly, the expert panel recommended that readmission to higher levels of care be examined separately so there is no penalizing of placing patients in a higher level of care, since this may be necessary and warranted. Now we will discuss the consumer experience measures. The consumer experience survey will not be administered by treatment programs during the pilot. This is something that we've received a lot of questions about, so I want to reiterate. We are not asking treatment programs or requiring programs to have their patients complete this survey in their treatment program. Instead, individuals will be able to leave feedback to a crowdsourced platform online. When they do so, they will be prompted to respond to these questions, which include reliable and valid questions pulled from CAHPS and ECHO surveys. We will ask that treatment programs encourage their patients to go onto the site and leave feedback in their own time, and we'll explore how this may be integrated in your systems, but it will not be a requirement. We plan that consumer experience will not be published on the rating system website until a critical amount of responses is reached, for example, 20 responses. Now moving through the consumer experience questions. The first is related to rapid access to treatment. Recognizing that some high-quality programs do have a wait, this measure may not be factored into an overall rating, but is something that patients and families have expressed that they need to know when selecting a treatment program. We will also capture elements of this measure in the treatment program survey, which I'll provide more information on. The consumer experience question is, when you needed treatment right away, how often did you see someone from this treatment program as soon as you wanted? The next consumer experience question is related to the principle around personalized diagnosis, assessment, and treatment planning, and asks, during your treatment, were you given information about different kinds of counseling or treatment that are available? This measure was deployed to ensure that programs are offering patient-specific care. The next measure is pretty straightforward and asks about the overall rating of the treatment program. Using any number from 0 to 10, where 0 is the worst treatment program possible and 10 is the best treatment program possible, what number would you use to rate this program? The next measure, measure 6C, is related to principle 6, access to fully trained behavioral health professionals. This examines the evidence of the therapeutic alliance, which has been shown to be highly correlated with better patient outcomes. The next consumer experience measure asks about whether the program talked about including family or friends in the counseling or treatment, and is related to our principle for access to non-medical recovery support services. The next consumer experience measure asks, how much have you been helped by the treatment program, the treatment you got at this program? This is starting to begin to address how the outcomes of patients in the treatment programs and is a patient-reported measure included in the consumer experience survey. And the next consumer experience measure asks about improvement in the ability to function. So compared to when you entered this program, how would you rate your ability to deal with your daily problems now? The last consumer reported measure is the patient narrative, or a space for them to respond overall to how a treatment program is doing. This is critical to include based on findings which revealed that when given the opportunity to report with open text, patients reporting on their experience in medical care settings tend to report on key themes that are outside of those included in the CAHPS and ECHO questions already mentioned. So this could include, experiences with billing or with parking or other things that might be important to the individuals as they're looking for care. Again, just to reiterate, we will not be asking for treatment programs to administer this survey with all of their patients. This will be an online platform where they will be able, individuals looking for care or who have received treatment will be able to provide feedback, and that the responses will not be made available or shared until a critical number is reached, a critical number of responses is reached. The last data collection mechanism is the treatment program survey. As a recap, we plan to administer the survey to all treatment programs at the facility level in the pilot states in the summer and fall of 2019. The treatment program survey will be available via an online portal. The survey will be pre-populated with information treatment programs are already reporting, for example, to NSATs when possible. The survey questions included in the public comment are subject to change based on both the public comment feedback as well as the field testing of the provider survey, which will be conducted by Research Triangle Institute. We are looking for treatment programs, as Leah mentioned, in the pilot states to participate in this field testing. And if you're interested, please reach out to the contact email at the end of the presentation, which is ratingsystem@shatterproof.org. The field testing of the provider survey will ensure that the questions are easily understood, possible to respond to, not overly burdensome, and consistently interpreted across different respondents. If you have any feedback on the specific measure concepts or phrasing of the questions, please leave these comments in the NQF public comments, as they will be addressed before the survey field testing. The survey examines mostly process and structure measures at this time, particularly because of the inability to consistently collect outcomes and risk adjust without consistent use of electronic health records. RTI will operate a help desk for providers during the time the survey is in the field, and we'll also work with state partners to identify early adopters. If you're interested in learning more, please reach out to us, but first I'll go through the provider survey measures. The first two provider survey measures relate to rapid access to treatment. The first measure examines the mean number of days between contact and treatment. This measure was expanded based on provider feedback into the next measure. This measure examines whether programs offer same-day access. It also asks whether programs admit clients after hours and whether there's a protocol for assisting clients to locate treatment if they do not have availability. The next treatment program survey measure asks about which assessment instrument is used at intake and whether information is collected about substance use, mental health status, physical health conditions, social relationships, and risk of relapse. The next treatment program survey measure is related to Principle 4, long-term care, and looks at continuous monitoring and adjustments to treatment. The question asks, does the program apply standardized assessments over time to determine treatment progress? If so, what outcomes are measured? How frequently are they measured? What instruments are used to measure outcomes? This is also a requirement by the Joint Commission. The next measure is related to Principle 5, concurrent coordinated care for physical and mental illness. This asks to describe the facility's highest level of electronic health system use. This was included in the survey after it was determined that many measures that relied on the use of electronic health records would not be feasible to implement in round 1 of the pilot, but instead that a baseline of electronic health record use is needed to be established. The next measure, also related to the same principle, concurrent care, examines whether the program offers mental health treatment on site, what types of mental health professionals are employed and for how many hours per year, or whether your program has an MOU with a mental health practice if services are not offered on site. Similarly, Measure 5C examines coordination with other healthcare providers when given permission by the client. Does the program obtain medical history, including prescriptions and current behavioral health treatment? The next question examines whether programs have a physician on staff, the ratio of physicians to patients, or if the program has an MOU with medical care practices. Next, this measure examines what type of therapies are offered by the program, whether they are offered individually or in the group setting, and how many patients receive each type of therapy over the past year. The next measure examines whether programs have a national accreditation. This information will be displayed on the rating system website. The next measure related to Principle 7, access to FDA-approved medications. The question is anticipated to be a multi-part question to determine which medicines are offered, whether they are offered on-site or whether they are offered through a contract with another provider. The measures may also include sub-questions regarding what percentage of patients receive the medication with specific diagnoses as a validation check, and the NSATs may also be used as a validation check. The last provider survey question examines whether a program offers recovery support services or whether there's an MOU with community partners to direct patients for these recovery supports, recognizing that they, just like the mental health or physical health services, may not be provided in-house, but we want to ensure that there's connectedness between these services. We want to now open it up to questions that you all have. Before we begin, we want to flag that if you have suggested changes to the proposed measures, please leave these in the NQF comments so that they're included in the formal comment review. If you haven't done so already, please send any questions you may have through the webinar messaging platform. We will also respond to some of the questions that were submitted in advance. I'm going to ask my colleague, Rebecca Rosenquist, to facilitate this session. Rebecca, I'll make sure your line is unmuted.
Yeah, I'm here. Thank you so much, Sam. Thank you, everyone. I'm trying to keep up. I know we have a lot of questions coming through the webinar platform, and also thank you to those of you that submitted questions in advance. I think broadly, and for those of you that are following the group chat, you can see there are a lot of questions about the measures themselves. I think that's one category. I think there are some other questions that fall under the effect or the impact on providers, and in particular different types of providers, as well as the reporting potentially in alignment with other demands on reporting, and then potentially also some next steps and then we can cover all that. But just staying in the focus of this webinar on the measures themselves, I think I'm going to ask Sam to respond to this. We have had there was a lot of interest now about the consumer experience survey, so a number of questions about that, Sam, about the what percentage of consumers we expect will complete the survey, and potentially any incentivizing of people to complete the survey. So I know that's something we have been talking about. If you could potentially talk about the ways that we've been thinking about that in terms of the consumer experience survey.
Yeah, absolutely. Thanks, Rebecca. So for the consumer experience survey, we're actually running a small pilot. Actually, RTI is running a small pilot in New York in order to test different mechanisms of promoting consumer responses to the rating system platform. So we will have results of that small pilot in June of this year, which will help inform the rollout once we have the platform built. So we'll be testing different mechanisms like having a card available at treatment programs, on the reception desk, or different mechanisms for promoting it. We'll also be working with our national partners and our state partners to promote awareness about the rating system. So we recognize that consumer feedback can tend to be pretty low, but that what we've heard from the folks in recovery or people who have family members in treatment who've been involved in this system is a really big willingness to actually share their feedback from treatment programs, because it was something that was missing for them when they were looking for care that they had thought would have been extremely helpful. And so through Shatterproof's own channels and through our state and national partners, we'll be promoting the rating system to all of the different constituencies and to end users to encourage them to submit the ratings, and also recognizing that because we would be masking that data until a critical number of responses is reached, it may be a different time period, a different time lag for how soon some programs have that posted about them.
Thanks, Sam. So I think there were a number of those questions about consumer experience, but I'm going to just move on to some of the ones about the claims-based measures. And so I know this is something we've been grappling with internally about the readmission measure, and there's been a lot of discussion around that. And so perhaps we could just touch on that a bit more. And the question specifically was that it's traditionally been viewed negatively by payers, and if we can give more of our reasoning behind referral to the higher level of care being what we're measuring here.
Yes. So one thing that we wanted to modify with that is that we are going to be tracking readmission, and we may not include that information in the rating that are going to be outwardly facing, because we know that if a patient needs a higher level of care, we don't in any way want to discourage them from moving up to a higher level of care. And so we would not want anyone to be penalized by that. But what we've heard from treatment programs is that having that aggregate data on how your program is doing compared to how other programs are doing in your region or your state may be useful in actually modifying and improving practices. And so that's why we're starting by collecting that measure and establishing a baseline.
Great. And Sam, I think it would be helpful to clarify, because we're getting a number of questions about it, about who is included in this rating system. We have a specific question about residential and intensive only, or non-intensive outpatient. So just some of those questions, you know, it seems to be some people on this call potentially are asking if they're a provider of behavioral health services, so should they be part of this? And also questions about, you know, if they just don't offer some of these services, they're going to be penalized in some way.
Yes, great question. So we know that addiction is treated across many different settings within healthcare, not just specialty addiction treatment programs, but for this pilot, that is our unit of analysis. So we will be focusing on specialty addiction treatment programs that are listed in SAMHSA's inventory of behavioral health services. This does not include recovery homes, sober living facilities, or individual prescribers of medication-assisted treatment. It does include providers of or specialty addiction treatment programs that span multiple levels of care or settings. So opioid treatment programs, residential programs, outpatient, intensive outpatient will all be included in the rating system. That said, there are a few specific measures, as you'll have noted, that are only applicable to certain levels of care. Obviously, if you're not providing that level of care, or treating patients with that condition, then you would not be rated on those items.
And I think following up in that vein, I know, you know, we have there's a lot of interest in the MAT measures, and we have specific questions on that, on if all clients in a program abstinent from all medications, what does that mean for the program rating? And so if we can maybe just give a little more of our thinking of the inclusion of the MAT measures.
Yes, so the MAT measures are meant to capture whether patients are on medication-assisted treatment using claims data during the course of their treatment, recognizing that that medication may not be prescribed by the treatment program itself. And so if it's a small substance use disorder treatment program, but they have a connection to, or an MOU with a prescriber to offer those treatments, that would be acceptable in this case, and it would fulfill the needs of that measure. In terms of all substance use disorders, we want to make sure that we're making information available and transparent to people looking for care, what medications might be available within a program or through connections to other programs. So, you know, not just for MAT for opioid use disorder, but for other substance use disorders, is that medication available in these programs or supported by these programs through a connection to another provider?
Great. So there seems to be some people who've on the call now who've seen earlier versions of the measure. So a couple of questions I think that get to things that people might be alluding to are missing from the current measure set. So just maybe you can give our thinking on why these things are or aren't included. One is a question on the reason for whether alcoholism and suicide risk prevention screening measures were removed.
Yes, so that was not removed. It was streamlined into the assessment question. So the assessment question examines assessment for mental health, behavioral health, suicide risk, physical health conditions, other medications, and substance use disorder assessment.
Great. I'm going to switch tack slightly. There have been a number of questions, and some of you submitted in advance, as well as some that's come up now about, you know, sort of how this might duplicate or, you know, become a burden for providers, and thinking about alignment with state reporting or other reporting.
Great. So that is something that we've been very conscious of, recognizing that a lot of the treatment programs we've worked with in designing the system have discussed reporting to a number of different places, you know, different commercial health plans, states, other areas, and not receiving a lot of that feedback back in a way that they can actually change their practices. So that's one thing that we've been determined to help deliver is actually a feedback loop to treatment programs. We've also been working with states to understand how we can integrate with any data that's already being collected. This will vary slightly by state when we roll out the rating system because each have their own quality initiatives or tracking systems in place. So more to come state specific on that item related to any data that may already be collected by state. But in terms of commercial health plans, we are trying to understand how we can integrate data that will be collected by us versus having 3 different groups collect the same concept, but 3 different ways. So trying to reduce the overall reporting burden for treatment programs.
Great. So we've also had a couple questions about the NQF process. I can answer one of them, which is on the extending the comment submissions date. That unfortunately we do not have flexibility on that. So as much as we would love to give those of you on this webinar, as well as many others, a longer time frame in which to provide public comment, we do not have control over that. And then Sam, I'm just wondering if you could clarify, because we did have a comment about how this is the NQF process that our measures are going through, and that this isn't the full NQF endorsement process, but the important role that NQF is playing in this process for us.
Yeah, absolutely. That's an important clarification. So this is not an NQF endorsement process. NQF has a thorough endorsement process, which they do measure by measure with expert committees. This process is a new sort of line of business for NQF, where they are examining the measure set as a whole and pressure testing the measure set independent of Shatterproof. So providing their expertise in convening and bringing the experts to the table, as well as the background research, which included the landscape review, the key informant interviews, and the technical expert panel, and then synthesizing and integrating these comments from the public comment period. And so that was what is included in NQF's work. It is, again, not an endorsement project. This is not going to result in NQF endorsement of the rating system, but will result in experts from the NQF convened experts related to the overall measure set, and that some of those measure concepts will need to be further refined by RTI as we move towards implementation of the pilot.
Great. So I know we have a number of providers on this webinar, including many that are from the 2 states where we've already announced that we're working, New York and Massachusetts, and we're thrilled that you all are part of this. So Sam, I think we have a question from someone who is one of those providers about really what's going to be required of providers for this and what's the best way to track for the data that's needed. So a little bit of that broader question about how this might affect providers.
Yeah, so what's going to be asked of providers, you will be, at minimum, sent a survey portal where we're asking for the completion of the provider survey. We would also ask for providers to promote the consumer experience feedback, but we are still in the process of determining how that will roll out, which again, we'll know based on our pilot in New York State. So, if we're going to provide cards, which you can make available, just leave out for people if they stumble upon them, or if you're, encouraging them, leave feedback on your experience via email or however you may communicate. So that's to be determined, but at minimum, we'll be sending the provider survey, which you just, we ran through those questions. And again, it's subject to change based on the field testing. And we'll ask programs to complete that survey. Right now, we envision having that survey portal open for multiple months to allow the flexibility to go in and submit information when it's convenient for you, to give you ample time to know when this is going to be coming out and the deadlines for completion. We will also have a number of opportunities that providers can be involved in the project voluntarily, completely optional, so including a provider roundtable for each of the pilot states where providers can receive updates from us on these changes that have been made, how we will be rolling out the project, and just an opportunity to ask questions. Through those, we will also be identifying our early adopters and some provider champions to work with and helping to integrate their feedback into the measure set before it is rolled out during the pilot. And Rebecca, did I miss anything? You and Leah can chime in about other ways that we're engaging treatment programs as well.
No, I think that covers a lot of it. I mean, again, as we've said a couple times in this presentation, for all the providers that are here or others as well, please do use this email that's on your screen to reach out to us. We're currently putting in place plans for the states where we've already announced, as well as we'll be doing the same in our other pilot states, and it's absolutely critical to us to be working with providers. Sam, we have a question in this, I think in that same vein of different types of providers thinking about how this might affect them. So a question on someone who says they're a small provider for our SUD clients, and they have a large amount of dropouts due to many of the programs available in their area. How will this impact our rating? And some of these questions I know we've been receiving from a lot of different people about, different size providers and how this that serve different populations and how this might reflect their rating and impact them.
Yeah, that's a great point. So a lot of those points are related to outcomes and retention and treatment, and those are critically important to understanding the quality of care. But it will flag that most of the measures we're looking at to display in the rating system at this point in time are process and structure measures. So trying to capture, the basic processes that are in place that should be available to patients regardless of where they're receiving addiction treatment, to make sure that those core components are available, those processes and structures are in place. And so those should be consistent across the different sizes and geographic regions. If there are areas where there's specific recommendations of how to tailor a question to ensure that we are capturing that element, we would be happy to hear that feedback as well.
Thank you. And I mean, I recognize that there are probably questions that we haven't gotten to here, as well as those that sent in advance. So please, if we have not covered something that you would like answered here, please do reach out to us. We're happy to answer all sorts of questions, and also have answers to frequently asked questions available on our website. So we really appreciate everyone taking the time today. In terms of next steps, as we've said a couple times, as a reminder, this public comment period that is being run by the National Quality Forum is open through March 1st, and we hope that you will take part and share information with your colleagues as well. In terms of next steps on the rating system as a whole, the feedback from the NQF public comment period will be integrated into final recommendations for the measure set that will be deployed in pilot states in the summer of 2019, this summer, working with our data analytics partner, Research Triangle Institute. And also in the coming months, we will be continuing to announce pilot states, and the rating system will go live in the pilot states in 2020 with a provider review period in advance to allow for user testing. So if you have further questions, please do send them to that address on the screen. And thank you everyone for taking part today.
Thank you, everyone.